Hello, everyone, and welcome to the TMA Ask the Expert podcast series. Today's podcast is entitled Diagnosing TM, NMO, and ADEM. I'm Gigi DeFibri from the TMA. We are a nonprofit focused on support, education, and research of rare neuroimmune diseases. You can learn more about us on our website at myelitis.org. This podcast is being recorded and will be made available on the TMA website for download via iTunes. During the call, if you have any additional questions, please send them to us through the chat option available with GoToWebinar. For today's podcast, we are pleased to be joined by Dr. Benjamin Greenberg and Dr. Islam Izbudak. Dr. Greenberg is recognized internationally as an expert in rare autoimmune disorders of the central nervous system. He splits his clinical time between seeing both adult and pediatric patients. He routinely consults on the inpatient units of Zale Lipschi University Hospital, Parkland Memorial Hospital, and Children's Health. His research interests are in both the diagnosis and treatment of transverse myelitis, neuromyelitis optica, encephalitis, multiple sclerosis, and infections of the nervous system. He is actively involved in developing better ways to diagnose and prognosticate for patients with these disorders. He has led an effort to improve biorepository development and has created uniform protocols for sample handling and analysis. As part of this initiative, his research has identified novel biomarkers that may be able to distinguish between patients with various neurologic disorders. He also coordinates trials that study new treatments to prevent neurologic damage and restore function to those who have already been affected. Dr. Greenberg is a member of the board of directors of the TMA and also chairs the TMA Medical and Scientific Council. Dr. Islam Izbudak is a board-certified neuroradiologist and an assistant professor at the Johns Hopkins Medicine Department of Radiology and Radiological Science, Division of Neuroradiology and Pediatric Neuroradiology. Dr. Izbudak joined the Johns Hopkins Neuroradiology faculty in 2006 after finishing her fellowship. Dr. Izbudak has been an active member of the Transverse Myelitis Clinic at Johns Hopkins Hospital. She most recently served as activity director for the 2015 Johns Hopkins Neuroradiology Review. Her research interests are about differential diagnosis of transverse myelitis, MRI findings of neuromyelitis optica and spinal cord and brain, and she has published multiple articles on these topics. She's also been interested in advanced imaging of spinal cord by using diffusion tensor imaging, or DTI, in both adults and children. She has also investigated the normal spinal cord DTI scalars in developing children. So welcome and thank you for being with us today. As someone with TM, I know how important a quick and accurate diagnosis can be. So to start off, Dr. Greenberg, can you just share an overview of what diagnostic tests you use to diagnose TM, ADEM, and NMO, and what diseases you rule out before coming to one of these diagnoses?
Well, thanks, Gigi, and thanks to the TMA. I'm happy to be part of the podcast today. This is an area that leads to a lot of confusion among patients and families, and frankly, it leads to a lot of confusion because a lot of clinicians use these terms imprecisely or incorrectly. And while there are agreed upon consensus statements about how to make the diagnosis of transverse myelitis or acute disseminated encephalomyelitis, ADEM, and NMO, these are things that are not often incorporated into the clinic. So one of the things that is at the heart of most of the confusion is around the term transverse myelitis. And what I try to remind people is transverse myelitis is a syndrome and a description of an anatomic location of inflammation and not necessarily its own standalone disease in some patients. So the term transverse myelitis just means inflammation in the spinal cord. So people can have inflammation in the spinal cord as part of broader diseases like ADEM or NMO or even multiple sclerosis, or they may have a condition with isolated inflammation in the spinal cord. And when we don't have a bigger syndrome involved, we just call it transverse myelitis or sometimes idiopathic transverse myelitis. So the difference between ADEM and transverse myelitis is by definition in ADEM, the brain is involved. So the current criteria for ADEM requires us to show evidence of inflammation in the brain. It may or may not involve the spinal cord, but it definitely leads to changes in brain function. Most patients with ADEM are confused at some point in the course of their illness. The difference between idiopathic transverse myelitis and ADEM is the location of the inflammation, whether or not the brain's involved. Neuromyelitis optica is different because it requires evidence of either recurrent disease over time or the finding of a very specific biomarker, this antibody, the anti-aquaporin 4 antibody. So you can have a patient with transverse myelitis who has a positive blood test for this antibody, and then they move from the diagnosis of isolated transverse myelitis to this disease, neuromyelitis optica, because we have identified the specific alteration that happens in their immune system. So when we're making these diagnoses, we take a history, we do a physical, we look at the patient first and foremost. We try and decide where in their body is the inflammation. We use MRIs to confirm where the inflammation is. Is it the spinal cord, the brain, the optic nerve, 2 out of the 3, 3 out of the 3? And then we use accessory testing like the NMO blood test to determine do they fit specific criteria for diseases like NMO. So all of that data needs to be put together before we make a definitive diagnosis.
Okay, great. Yeah, that was a really great overview. So you talked a little bit about some of the testing you do, and you mentioned the NMO blood test. Are there any other tests to get someone to go from a diagnosis of TM to something like NMO? And is there a difference in how you diagnose patients, you know, that are children versus adults?
So the only specific blood test, if you will, or biomarker for identifying NMO patients is that NMO blood test, the anti-aquaporin 4 antibody. But there are people who are negative for that blood test, but still fit the criteria in the pattern of NMO. And in those patients, what we require is a certain pattern of inflammation, evidence that the spinal cord and the optic nerves have been involved. And in some patients, we require evidence to show that there's been more than one event over time. So when the blood test is negative, we're using our clinical skills, history and physical taking. We're using MRI technology and sometimes technology to look at the optic nerves, something called OCT, to try and build a case. It's like presenting in a court of law, the legal case of, does this person have evidence of inflammation in a pattern that we see in NMO despite the negative blood test? There are no other specific blood tests for any of the conditions we're talking about that would allow us to differentiate them from each other. And that's something where we're spending a lot of time on the research side.
Okay, great. And then, Dr. Isbudak, what kind of imaging do people get to be able to get a diagnosis of a rare neuroimmune disorder?
Hi, thanks for having me here. First of all, I'm happy to be part of this podcast. The types of imaging in diagnosis of all these entities, if we are concerned about spinal cord, we do the spine MRI. Spine MRI consists of multiple different imaging planes and imaging techniques that shows different components of the spinal cord. This is a regular spine MRI at the end of the day, that when you have even a suspicion of a disc herniation, you would get the similar MRI, which shows actually the anatomy of our spine. Because while we are trying to diagnose these rare diseases, first of all, what we do is we rule out the things that are not inflammation that can be treated surgically or in other treatment methods, such as tumor. Is there a tumor in the spinal cord, or is there a mass effect on the cord causing this? Or sometimes is this a reflection of a disease that the patient has already had, such as metastasis? So imaging rules out many diagnoses, and also when those are ruled out and all we see on imaging could be, and most of the time it is the spinal cord being a little bit swollen, maybe, sometimes it's not swollen. It could involve only cervical spine, or it could involve cervical and thoracic spine, or sometimes only thoracic spinal cord. And then we see a bright signal in the cord. which is on T2 weighted images, a certain type of image acquisition technique that shows bright, very bright cord, which reflects actually edema at the end of the day. It's edema for some reason. It could be inflammatory, infectious, or it could be even ischemic. So after seeing these signal changes, then we give contrast, IV contrast dye, and we look if these lesions, one or two or more of them, show any contrast uptake. So what will appear is on a particular sequence, T1 weighted images we call them, we see that in those areas there is brightness and contrast enhancement, we call it. That contrast dye has been particularly loculated in that region, pointing us that there is something going on, probably inflammation, or it could be a tumor if we are trying to rule out that. So those are the main, and in addition to spinal cord, most of the time we also do brain MRI, especially when the patient shows signs of confusion, as Ben said, or more severe condition, even seizures, or really not very conscious, or optic nerve findings. Then we do brain MRI, and we have multiple different sequences, images we acquire in the brain MRI. And we also specifically look at the optic nerves and optic chiasm if they are involved. And again, we look at after we gave the IV contrast dye into the brain and see if there are other lesions in the brain, if it's a disease isolated to the cord, or if it's a disease that involves both the brain and the cord, such as in case of ADEM, or is it only transverse myelitis and inflammation of the cord? I think that's basically what we are doing.
Okay, great. Thank you. So this is for both Dr. Greenberg and Dr. Isbudak. What ongoing monitoring do you recommend for individuals with these disorders? And for how long do you monitor patients for? For example, I was told to receive yearly MRIs for about 10 years after diagnosis, after which I can receive them every other year, even though the images look the same year to year. So if you could just talk a little bit about that, that would be great.
Ben, you
yeah, so I'm happy to dive in on this. So the first issue is there should be very individualized recommendations for each person based on their history on what the surveillance should be. And I think the important thing is to understand how we use ongoing MRIs, or at least how I use ongoing MRIs relative to these conditions. So the first thing to recognize is there are very poor correlations between how an MRI changes while somebody is recovering and their functional outcome. So I've seen after patients with ADEM or transverse myelitis who have an acute inflammatory event, I've seen patients who have great looking MRIs but have a lot of deficits, and I've seen patients who have horrifically looking MRIs who recover fully. So the follow-up MRIs in general are useless for tracking somebody's progress after an event. So then it begs the question, why would we get them? And for me in the clinic, there are two situations where we're doing follow-up MRIs. So number one, as was already mentioned, if there's a question about the actual diagnosis, maybe we were trying to decide if it was transverse myelitis versus a blood flow issue versus a tumor, we can use the MRI to track things over time to see if it changes in a way that makes us second guess our original diagnosis. But more often, if we're sure, or as sure as we can be about the original diagnosis, the follow-up MRIs are there to look for new inflammatory events. So as I said, some people with transverse myelitis, that condition was caused by a larger, if you will, systemic condition. Maybe it's neuromyelitis optica, maybe it's multiple sclerosis. And often in inflammatory conditions, there can be asymptomatic events. So somebody can be doing great, feeling wonderful, but a new inflammatory event happens in the brain that they have no awareness of, no symptoms from, so the only way we capture it is by doing the follow-up MRI. So when we see patients in our clinic, what we do is risk stratify them as to what condition they have. So I may say to them, listen, your diagnosis is transverse myelitis, but there's a pattern to this that makes me very concerned about multiple sclerosis as a possibility, so I'm going to do surveillance MRIs in you over time. There are other individuals where I'm far less concerned about diseases like MS, so the surveillance is lighter. In general, after a first event, the majority of people who have MS will prove it to us over the first 5 years. So it's rare for me to do surveillance MRIs out past the 5-year mark because frankly, it's if we haven't proven it was MS by then, it almost uniformly isn't. And so there are individual reasons that practitioners may change that plan, may have more frequent or longer surveillance, but in general, that's what we're looking for. We're looking for evidence of new inflammation.
Yeah. As neurologists decide how they will follow up the patients, and if they ask for follow-up MRI, that's what we see in our routine clinical work as neuroradiologists. So most of our follow-up patients are MS patients. And if someone had a first-time transverse myelitis and clinically treated, usually for the surveillance period, we see their MRIs, and usually we see that the lesions slightly subsides and disappear, or there's a very small residue. So those type of changes. And Ben is very right about no correlation between clinically how patient is doing and how the pictures are changing. So the clinical findings are much more valuable than the picture because we still are not there yet with the best imaging study. MR is much better than what we had until so far, but it's not the perfect solution, and it doesn't show everything to its capability so far. But from our perspective, I'm not in the situation that you should do follow up for this type of situation or that. But I think we all know and accept that the patients needs to be followed up by their neurologist. That's the most critical thing in my view. They shouldn't be lost and go away and never come back. That's very wrong thing to do from a patient perspective, because being treated and doing completely well doesn't always mean it won't come back, and being under close follow-up of a neurologist is very valuable. That's the main thing, I think, in the follow-up cases.
Okay, great, thank you. Yeah, I think it does make a lot of sense. You have to speak to your individual provider as well and get the follow-up that's recommended as best for you as a patient. So we actually just got a question that came in that was referring to Dr. Greenberg. You said earlier that transverse myelitis is kind of this broad category rather than a specific diagnosis, and how it can be seen in ADEM as well as NMO. So this person is asking, my first symptoms appeared in late 2007, and I finally received my diagnosis of TM in 2010. I'm still dealing with all of my original symptoms, so at this point, would it be possible to uncover an actual diagnosis? Also, does it really matter other than to properly categorize my disease?
So it's a good question, because what it gets to is the notion of separating out long-term symptoms as a unique issue in these diseases. So it is possible to have a one-time inflammatory event, idiopathic transverse myelitis, and for the diagnosis not to be made initially. A lot of patients are misdiagnosed as Guillain-Barré. Some patients are misdiagnosed. My favorite is a pinched nerve. And often the actual diagnosis of what caused the onset of that condition isn't made until much later. The reason it's important for the diagnosis to be accurately made, even if it's years later, beyond, frankly, the research and the binning and categorization of patients, is because our approach to symptomatic management changes if we understand that this is a spinal cord-based event versus a peripheral nerve event or something else. And also, it gives a clear course for patients as technology and science change. What should they be paying attention to in terms of as new therapies become available or interventions? And so correct diagnoses are important, not just because I'm an academic and I want to make sure the research is correct, but also because practically I think it gets patients synced in with better symptomatic management.
Okay, and so are underlying autoimmune conditions that could have contributed to TM automatically looked into or ruled out during diagnosis?
Yeah, I wish. You know, I'd love to get to a world where every TM patient is accurately, efficiently, and quickly diagnosed, and then the appropriate evaluation for systemic issues are done. We are a long way off from there. And so until I see, when patients are referred to us for evaluations, until I see the primary records of what lab tests were sent and how they were sent and what was done, it's very hard for me to comment on has somebody had an appropriate or thorough workup. There's so much of this that's still art. I mean, as I work with my radiology colleagues, and it's a good conversation to have, there are nuances on MRIs that can make me think about a case completely differently, and depending on a radiologist's experience with this, make a big difference. So if I have a transverse myelitis patient where the radiologist or myself identify inflammation within the meninges, not just the tissue, but the spinal cord tissue, but the lining around the spinal cord, all of a sudden certain conditions become more concerning to me that I might not have gone after. There's something called sarcoidosis, which can cause meningeal inflammation. So a lot of this has to do with having an experience with it and knowing when a red flag should go up, when there should be a concern in our mind that we're not dealing with a garden variety case. And so, unfortunately, it makes it hard on our patients and families to know when has my workup been complete. How do I, there's a certain amount of faith and trust that goes into this. We are living in an age where our consumers, our patients, are much more educated, which is great. And so we encourage people to get informed, get educated, and then ask the hard questions of their clinicians. Have you considered NMO? Have you considered sarcoid? Is there anything else that should be done? Is there anywhere else I should be seen or evaluated? And I think most clinicians are welcoming of these conversations. Some still aren't.
I think the problem arises from dealing with a rare disease. I chose this topic to work on because it wasn't well known, and I wanted to learn more and teach everyone in my field so they don't miss or misinterpret these findings. But imagine that out of 1 million people or 100,000 people, I think on your website there's a statistics like 3 to 6 patients per year in a hospital. So if only 6 TM diagnoses made in a hospital, and if you consider there are hundreds of doctors working or tens of doctors working in a hospital. So I'm talking about a general hospital. I'm not talking about Johns Hopkins. So the odds of the physician thinking about this being a cord inflammation versus a pinched nerve is very low. I think that's the main problem. Dealing with a rare disease and thinking about it when the patient first comes to the either the office, doctor's primary caregiver's office, or usually it's not to the ED service, but let's say to the ED service. The doctors there should think about that diagnosis. When the moment they think about it, then they ask for MRI. And when the MRI is done, it's the knowledge and experience of the radiologist to think about inflammation of the cord, and there is a disease that's called NMO, transverse myelitis. No, I'm not dealing with a compressed cord due to disc, or I'm not dealing with a tumor, although maybe they see more tumor than inflammation. So being rare is the disadvantage of disease in my view, and also that because of that, I don't know how there should be some kind of protocols or check mechanisms. I'm sure in every medical school or neurology, neuroradiology training, we teach those entities. Everybody's taught about it, but you know, in medicine, learning comes with seeing the patient and making on your own first diagnosis, or missing a patient with this disease. Then you never forget about that. So I mean, in my ideal world, in every primary care office or every ED in the small hospital, big hospital, or Johns Hopkins, that the physician thinks about I'm dealing with inflammation of the cord. I think after that, it's almost in our situations in big institutions, it's almost routine that all these tests are done for SLEs, CO grants, or oligoclonal bands for MS, and viruses, HHV6 and cytomegalovirus. So everything in big institutions are tested. And from my perspective, if I was a patient and if I'm dealing with something bizarre and not in disabling my walk and my urinary functions, I would take it very seriously, and I would try to go to the best hospital that I know in my area, or I would expect that my provider would recognize that this is really an important acute situation, and I recommend you go to this institution because they are experts in that place. I think that's the way to approach it. I mean, I think that's an answer to the question.
Okay, great, thank you. And you know, we talked a little bit about how transverse myelitis is so rare and how that makes it difficult to find providers who know how to diagnose it properly and treat the symptoms afterwards. So that relates to one of our questions that we got in. Someone wrote, I have had a long and rocky road since 1999 to finally arrive at my diagnosis of idiopathic transverse myelitis. Some of my worst symptoms have subsided over the years, but I continue to have nerve and muscle issues. I'm having trouble finding a doctor to monitor this health issue. Seems that since it turned out not to be MS, no one is very interested in helping me. But they would like to know what to expect and how to determine if certain symptoms are from TM or other causes.
Yeah, so this is very difficult because a lot of times patients who have had transverse myelitis start to develop secondary issues from long-term spasticity, muscle weakness. They can get joint changes. If somebody is walking for years in a slightly abnormal way or a majorly abnormal way, then the hips, the knees, the ankles, the back all start to change. And what started off as transverse myelitis can turn into transverse myelitis plus a lot of orthopedic things. And so it does take working with a healthcare team, working with people who are invested, and it doesn't have to be a neurologist. In fact, in most places around the country, it's not a neurologist who takes the lead on these issues. It's a physiatrist, a physician, an MD who is trained in physical medicine and rehabilitation, because they're used to managing the long-term impacts and the rehabilitation issues related to spinal cord injury, which TM shares a lot of similarities to. So often what I say is, instead of focusing on trying to find a neurologist, broaden the search to include a physiatrist and see if there is better success in managing long-term issues when working with a physiatrist. The alternate option is to head to one of the several centers around the country where there are clinicians who spend more time on things like TM for a one-time visit, but do so with a local physician. It can be a neurologist, it could be an internist, it could be a physiatrist, who is willing to partner up with that institution. So we have patients who come to us just once, and then we, after the visit, call their home neurologist or physiatrist and give advice. And then we can stay in touch with that clinician and give updated advice over time on how to manage different issues without the patient having to constantly come back to our clinic. So there's a couple different ways to go to try and get access to some of the expertise or knowledge around these conditions.
Thank you. And then, Dr. Isudok, do lesions on the spinal cord show up differently on an MRI rather than inflammation?
I think this is a semantics, the difference is. Inflammation is a medical term describing, or what term is it, Ben? Histology term? Inflammation?
Yeah, this is where we all struggle. So you'll hear clinicians, radiologists, everyone use the terms lesion, plaque, white spot, inflammation. Again, I think it personally goes to the imprecision of the language we use around it, and sometimes both clinicians and radiologists are guilty of labeling something based on our interpretation of the data versus just citing what the data is. So there's an abnormality on the MRI that we suspect is inflammation, but we haven't done a biopsy to prove it. And so I'd love to hear your thoughts on the classic radiology report is supposed to separate out the findings from the impression, and it's often those lines get blurred, and it might be useful for everyone to understand what the differences are between those two parts of a report.
Right. So in findings part of the report, we describe in which parts of the cord what we see abnormal on which image. And then in impression, we give our, with these findings, when this one finding with the other two findings are together, that makes me think that this we are dealing with neuromyelitis optica versus, because I don't see, this is the impression part. I see this and this signal changes. Overall, it's signal changes. And therefore, with the history given to me and the age of the patient, and with these imaging findings, I think we are dealing with either this and that. So that should be the way of radiology reports. But some reports are confusing, some reports are not to the point or clear, and there is also the issue of not committing to one or two diagnoses and putting every possible possibility of diagnosis into the impression. So there are efforts to change and more standardize the imaging reports in the radiologic societies in all over the world, but also North America. And there are some fields now, there are some standard reports. So that makes things a lot easier for especially the clinicians. But there's so much also resistance to go into a standard reporting because then some colleagues think this is the art of our profession. And I don't want to limit myself to one of the three options of findings. I want to describe it well, and I want to make it clear approaches. So to go back to what you're saying is inflammation is not an imaging term. As a radiologist, I should use my radiology terminology. So that's why I said it's histology or histopathology terminology, inflammation. So I'm not doing a microscope analysis. So I use a signal change, or bright signal or dense, depending on what modality we use. We use MR for this rare diseases of inflammation, and we use MR terminology. And so then whatever we describe as lesion could be histologically some inflammation or some healing of inflammation, some gliotic change. But these are all, again, histopathologic words. And I think every discipline should stick to their capability of what they are seeing and interpreting. But it's difficult to really standardize the language. I think talking in detail helps patients to understand what's going on. Also, communication in between clinicians and radiologists and patients are very helpful too. I think I encourage people to ask questions to their doctors, radiologists, or, it's good to get into conversation and learn more.
Right, and I think your answer also speaks to the, that clinicians should talk to one another. So, your radiologist should talk to the neurologist, and so everyone's kind of on the same page.
Yes. Rather than speculations, it's better to discuss and understand what we are on each side, what we have in our hands, and what all these sum up to.
Okay. And then we've talked a lot about the spinal cord and brain, but does an MRI show if there is damage to peripheral nerves? And if not, how is this known or diagnosed?
I can answer the MRI part. Peripheral nerves nowadays can be imaged by MR neurography, so it's relatively a new technique, and not every center does it. It's you need to really work on with the MRI technology and your parameters, and somebody should be dedicated doing it, and it takes a long time. But MR can show peripheral nerve pathology, but not the spine MRI, because spine only shows the cord, spine MRI, the vertebra, the discs, the nerve roots, but not the peripheral nerves. And there are other tests that can be used, which Ben can tell us about.
Yeah, so I agree completely, though. And since MR is not the test of choice to diagnose nerve damage, the actual test of choice is a physical exam, believe it or not. There is few things that are better than physical exam at identifying nerve damage. Once on a physical exam I suspect nerve damage, then the gold standard is to do a test called a nerve conduction study, or EMG. This is an electrical test with electrodes on the skin or needles in the muscle, where we can look at the transmission of a signal along the nerve and see if it gets from point A to point B with the amount of force and speed that we expect. Sometimes, and that test can measure the medium to large size nerves in the periphery. very small nerves cannot be measured by that. So if we have concerns for a small fiber neuropathy, peripheral neuropathy, skin biopsy, and we look at the nerve endings in the skin. So it starts with a physical exam, and then the nerve conduction study or the skin biopsy is there to confirm what we suspect, tell us the pattern of what's going on, so we can try and identify a cause. But as we stand here today, MR is not the first choice for diagnosing neuropathy, although the technology is evolving, and for the large nerves and nerve roots, we're seeing a lot of progress in MRIs helping us understand what's happening to the nerves.
Okay, great, thank you. And so another question that came in, Dr. Greenberg, is will there always be spots present on an MRI with someone with a rare neuroimmune disorder like TM, ADEM, or NMO?
No, so we do not expect for the previous lesions to fully go away. Most of the time in TM and NMO, if we look very carefully, even with full recovery, we can find subtle changes in the spinal cord. And again, it goes back to the lack of concern I have about correlating what happens to the MRI and what happens functionally. I encourage people not to worry about the MRI of what happened being followed over time, because that's not what's going to predict or correlate with outcome. And without getting too far into the science of it, the MRI measures basically water content, how these water molecules flow throughout every tissue and cell in our body. And so I could have a person who has inflammation in the spinal cord and then fully repairs it, but does it in such a way that the water content is a little different than the original. So on the MRI, there'll still be a spot there, but the person's fully recovered. And so I don't worry as much about the lingering or resolution of the lesions that we see on MRI in ADEM and transverse myelitis and NMO. I worry about what happens to our patient, and then using the MRI as a tool moving forward to monitor for new inflammation. So just like a diabetic checks their blood sugar, even though they feel fine, they check their blood sugar to see what it's doing. We use an MRI to check the nervous system of a transverse myelitis patient or NMO patient or ADEM patient to see if there's new inflammation, even if the patient's feeling okay.
Right, so it seems like MRI is just one of the many tools you use, along with the physical exam, to see what's going on.
It is. So it's the most important tool we use is keeping in communication and talking to our patients and letting them know when they need to alert us for changes. And then the MRI is there as our backup to survey for changes the patient may not be aware of, as well as to better characterize if somebody's experiencing new symptoms, what's driving it.
Okay, great, thank you. And then we had another question that came in. My understanding was that a diagnosis of idiopathic TM is a one-time occurrence. I was diagnosed in 2007. I've had 4 major flare-ups requiring IV treatment to settle the pain down. I was barely able to walk during them. Is that common? No new lesions on spine have been noted, and non-specific spots were noted on the brain MRI last year, but the doctor doesn't seem concerned.
So I'll give my part of the answer first, and then we can talk about the MRI. So it is very important for everybody, patients, families, clinicians, neurologists, radiologists, to understand that a flaring of symptoms can occur without new inflammation occurring. And it is critically important to just absorb that and think about what that means, because what it means is you can have quote-unquote flares where symptomatically you're doing horribly, but there is no new inflammation in the brain or spinal cord. And they will be called relapses or flares by mistake. The term we use are pseudo-exacerbations, because the important thing is in that setting, you're not having recurrent inflammatory events, you're just having worsening symptoms. And there are a lot of reasons, and we can dedicate a whole hour onto why that happens. But So when somebody calls with new symptoms, I rely on the MRI and my radiology colleagues to very carefully look for any evidence of new inflammation, because that's going to make a big difference to my management. If there's new inflammation, then yes, I use steroids or plasma exchange or IVIG to reduce the inflammation. If there is no new inflammation, then I try to find out, why are the symptoms getting worse? And there are a lot of causes for it. And so I've had lots of patients come into clinic over the years who were managed for, quote, relapses, when in retrospect we were having pseudo-exacerbations and the diagnosis of idiopathic transverse myelitis was correct, which is a monophasic disease. If somebody has recurrent inflammation, proven recurrent inflammation, then we no longer diagnose them as idiopathic transverse myelitis. We need to think about broader recurrent conditions.
Yeah, I think it's completely a clinical point, flares, because we don't see patients when they have flares, and what we are involved is to look for new inflammation, so we look for that. But I think clinically that I am not knowledgeable about the details, but there are different ways of exacerbations of some symptoms that only the neurologist can.
But, you know, this gets to your point about the communication. For these complicated situations, what's helpful to the patient is for the neurology colleagues and radiology colleagues to communicate, because if I pick up the phone and say, listen, I'm most concerned about a, you know, upper thoracic small amount of inflammation, then the radiologist may modify the study to get a better look at the areas of biggest concern. And I'm sure you can comment at length about the lack of communication that comes when studies are ordered.
Yes. Oh gosh, that's the biggest problem. Even when you say, I call and say, a neurologist calls me and say, hey, I'm worried about the upper thoracic spine injury, I am already happy. I know what's going on, and the neurologist calls me and tells me, so I'll go and look for it, and maybe we will do this addition to that kind of teamwork. Yes, and especially in big hospitals, that communication is lost. A paperwork gets in, and we do the routine, and we don't know what's going on. Yes, unfortunately, we have that issue. But at the end of the day, if you're looking for, we have a standard of screening the images. We look normal, we look abnormal things, we compare with the latest study, and we try to decide if there's a new lesion or if there's a new enhancing lesion. So these always should be in reports. It's a standard. But being pointed to one area would help. Maybe the problem is, ideally in a situation that you have only 30 MR cases per day and you are monitoring each of them in smaller institutions or imaging centers, I guess, or hospitals. It's the ideal situation, because you talk with the clinician, then you know, and maybe although the study ordered without contrast, you suspect something and want to give you contrast, for example. Or in my case, like diffusion or DTI weighted imaging. If I have learned that there's a very acute change, I can add the diffusion weighted imaging, which we try to achieve by calling before doing the study. Sometimes the technologists have some questions, talking with the patient and looking at the requisition. They think maybe there's something else we need to do, and they call us, and then we call the clinician and we talk with them before we do the study. everybody tries to do their best in that way. And ideally, of course, we always want detailed information. Not, I mean, detailed meaning rather than saying a relapse or attack, it could be new right arm weakness, or especially if something like I'm worried about a lesion in thoracic cord. I never get that. Almost. I would love to be pointed like that. Uh, so it's very important. Absolutely.
Great, thanks. And Dr. Izadok, you just mentioned diffusion tensor imaging. Can you just talk a little bit about how DTI is different from regular MRI and what advantages it offers for diagnosis?
It is, DTI has been used extensively in brain, but not in spinal cord. So it is still a research tool. And over the years, in last 10, 20 years, there has been improvements in the technique because just to get good images even was difficult. With the new MRI machines and with their advanced techniques, now we can get in almost all companies, new scanners, you can get diffusion images of the cord. But again, a dedicated radiologist should optimize the parameters, and usually there's a need for a help of a physicist, a PhD person in biomedical engineering. So that makes it even harder to be in use for clinical applications. So it's hard to say, oh yeah, please go ahead and ask for DTI imaging, because it's not possible in most of the centers. But I think it is slowly maybe getting there. Like in brain, we use diffusion weighted imaging for every patient in routine. Maybe one day the technology will be there and available and not dependent on the MR technologist picking a wrong parameter, or the patient moving would not affect the quality of the images, and maybe we will use it better. But mainly, its biggest advantage is to recognize stroke. So in brain, that's made a huge difference in care of the patients. And in cord, although it's very, very rare to have spinal cord ischemia or stroke, when it happens, you can diagnose faster with this technique. But it's in the early phases. It's very difficult to get reliably good images every time in every condition in every hospital because of its own challenges of the spine, as we have a moving CSF, cerebrospinal fluid. We have pulsating heart in front of the thoracic spine and breathing someone, and very small cord adjacent to that, a bone, which all these structures make the picture very difficult to achieve. But it is doable right now. It's much better, and we have used in some research. And what it shows us is the microstructure of the cord. So more advanced information and functional information we get from DTI. So what it shows mainly is, again, the movement of the water in the spinal cord tissue. And when there is a, for example, stroke or ischemia, the movement is completely blocked and captured and in the cells. And this looks differently in this technique compared to another type of edema, water pooling in some area, which is related to just pure inflammation, no stroke. So that it could help us to differentiate if someone presenting with the findings of acute, very acute paraplegia, paresthesia, is because of a stroke or it's because of an inflammation. That's one good way of using it. And the other, you get quantitative information. So you can look at certain regions and get the quantitative information and then compare it with the normals. And then you can use that quantitative information when you follow up your patients to see if there is improvement on cellular level, or you can say what kind of outcome do you expect with these quantitative values. It's much more advanced than seeing a T2 bright lesion on cord. You know more about that with this technique, but it's in the early stages and still at research phase.
Great, thank you. It seems like DTI will be maybe used more once there's a little bit more research about how to use it in the spinal cord. And then Dr. Greenberg, some of your research focuses on identifying biomarkers. Can you just talk about what a biomarker is and how biomarkers can be used in diagnosis?
Yeah, so the best example of the biomarker relative to diagnosis, at least one that's currently used, is that NMO antibody, the anti-alpha-1 4 antibody. Because what a biomarker is any type of test, anything outside a clinical exam or a history. So it could be an MRI image, it could be a blood test, it could be a spinal fluid finding that tells you something about the biology that is meaningful, meaning it has a predictive or prognostic capability, or it tells you what therapy will be best for the patient. So we are working on a whole slew of different types of biomarkers to improve our care of patients. So one of the biggest questions we get from patients is, I've had transverse myelitis, could I ever have it again? And we would love to find biomarkers to tell us who fits into that category versus not. And we have a range of different projects going on to study patients, study their blood and their spinal fluid, so we get better at predicting. And I encourage everybody listening to think about what role they can play in clinical research. Everybody's story is meaningful, everybody's experience is meaningful. What's most important is your clinical care, but as you are going to different centers, you may be asked to take part in different research projects. A lot of it is about sharing your data or sharing a blood sample or sharing your MRI image, and the more that gets shared from our community, the smarter we get. So whether it's on your own at an institution or with the Transverse Myelitis Association, we have something to learn from everybody who is listening to the podcast right now.
Great, thank you so much. I really appreciate both Dr. Isbudak and Dr. Greenberg for you taking the time to speak with me today and also answer questions from our community. We really, really appreciate it. Unfortunately, not all of the questions we got could be answered today in the amount of time that we had, but we look forward to continuing this dialogue through more podcasts throughout the year. And I just wanted to remind everyone listening that this podcast was recorded and it will be uploaded on our website. So thank you very much.
Thank you.